The new science of pain and the cutting edge of the research that we're doing at the moment is very much about this whole idea of change or plasticity in the nervous system. And it's about how using all these multiple factors can feed in, as we've been talking about, to damping down that sensitivity in the nervous system and reducing pain. So we have been calling this the whole person approach. The whole person meaning multiple pathways to get the effect and to help with this whole recovery process. And this is a study that's been done in some rats, and these are rats that are not stressed versus rats that are stressed, and it's a slide showing the nerves in the brain of those rats. There are in fact more neurons, as we call them, and more connections in the top one and fewer in the bottom one, which is to say that when you subject a rat to stress, you change the nervous system in that rat in unhelpful ways. But the good news, if you're a rat, or if we're human beings as well, if you de-stress the rat, it can shift back up to what it was before. So this loss of neurons, loss of brain connections doesn't have to stay like that for the rest of the rat's life. But the issue is the stress and the amount of stress that the rat or us human beings are under can affect our nervous system in potentially unhelpful ways. This is another interesting study that's been done in humans this time. We're looking at human brains, looking at a group of people who had back pain early and following them for 12 months and looking at the end of 12 months as to whose back pain was recovering and whose back pain was keeping going, who was getting into that persistent or chronic pain stage. And they found out, because they did these functional brain scans early and late, that it was possible to predict from the early brain scan, a few weeks in, who was going to be recovering and who was going to have pain that was persisting. And you can see that, I don't know how well it shows up in this, but this orange pathway here is more marked in this group who had persisting pain and less marked in that group there. And what this pathway actually represents in terms of the brain areas involved was a link between the physical sensation part of the brain and the emotional processing part of the brain. So in the way that we're interpreting that, if it is just more predominantly the physical sensation associated with the tissue injury, then usually we would expect that to heal and the pain not persist. On the other hand, if there is some emotional trauma around the time of the onset of the pain, then it really imprints the brain pathways in a different way. So maybe two people have a similar physical injury, one of them goes on to get chronic pain and the other doesn't. It's virtually always the one with the greater degree of emotional trauma around that initial injury who will go on to get the longer term pain problem. This is similar in a way to the brain imaging research with post-traumatic stress disorder, and it's the issue of where there is an emotionally traumatic aspect to the injury that then becomes much more likely to change the nervous system and contribute to pain that persists.
I had an injury 20-something years ago. I used to be a field surveyor. I was the chief surveyor of infrastructure on the world's largest construction site in London 20 years ago. And I had an accident at work, and I went from, a position like that and lunch in London, Paris and New York, and you get a broken leg and you're in hospital and you get flowers from the managing director, and then the next day they cancel your paycheck. 3 months later you look like being homeless. 2 years after that you've had 7 operations and you're nearly broke. You're living on credit. You're waiting to win the law case so that you can pay back the credit and maybe get on with your life. And you're always thinking, well, it will all be over soon. All this is why I don't feel well. Well, it isn't. It's the way you react to it is why you don't feel well, or to a large extent. The pain specialist I spoke to before I came to the course here at HIPS in 2012, he drew a link. He didn't like coincidences. He didn't like the fact that, I had had significant people in my life were killed in the Bali bombing. At the same time, I'm complaining about aches and pains and chronic fatigue and those sorts of things, but the symptoms predated all of that, so I was a bit dismissive about that, although, you know, there was something to it. But most recently, it's had some resonance, because sitting down here last week, plotting down things on that timeline, like what's happened in your life, it makes you rethink a great deal about the impact of a story, as they call it here, on your aches and pains and suffering.
10 years ago, we were saying that if you've got long-term pain, start on some medication. Maybe we'll sign you up to some OxyContin, and we expect this to work over the rest of your life and not have very many side effects. Unfortunately, we got that wrong. As the studies have come through, we now know that these medications don't work well over the long term. They can work fine short term. Morphine and cousins, OxyContin, are called strong painkillers, and yes, they are strong painkillers for short-term pain. If you have an operation and you have a high level of pain, the anaesthetist gives you some morphine, it's quite possible to drop the pain down to zero. But in long-term pain, these are not strong painkillers. They don't work very well. So this is a graph that gives an idea of how well morphine and its cousins might work in long-term pain. This was a group of people whose average pain score was about an 8 out of 10 and given morphine for their chronic pain. And you can see that their pain scores did drop, but not very much. So from about an 8 to about a 6 out of 10. And that's what we would expect to begin with, that you can get modest benefit from using this sort of medication. But then what happened over time, 4, 6, 8 weeks, was that the pain relief got less, so that by the end of that time, the pain scores were almost back up to where they started. So this is the issue of the body developing an immunity to the effects of the medication, what we call tolerance. We do say now that medication like morphine and cousins can be very effective for acute pain. It is good if you break an arm, if you have an operation, but our recommendation now is that these need to be stopped after a certain time. Many times these medications can be stopped after a week, but even in complicated situations, we recommend that they're stopped within 90 days or 3 months and not longer. So in that situation, the 90 days in a complex situation gives someone, like with the nerve blocks, the breathing space to get going with the other strategies. After that time, the medication is ceased.
We all accept medicine advances as knowledge grows. In treating chronic non-cancer pain, there's been too much focus on opioid medication and not enough on the most effective ways to improve pain and well-being. Most people taking opioids experience early gains, but it doesn't last. Taking more may seem to help at first, but in fact it makes matters worse. Along with well-known side effects, scientists have also discovered that people taking opioids often develop other problems. They're more likely to fall, have lower sex drive, lower immune function, and poorer quality sleep. There's also an increased risk of accidental overdose and death. We now know that opioids can quickly sensitize the nervous system and actually increase pain. Some people using opioids say it gives them a little bit of comfort, but that's not a reason to remain on them. There are also those who develop addiction, and this makes it very difficult to stop opioids, despite the harms. Knowledge changes. We now know that when it comes to chronic pain, use of these drugs often makes matters worse. Opioids are no longer recommended for chronic non-cancer pain. Instead, get support, get an active recovery plan, and get started.
So the benefits of these drugs are not as great as we had hoped 10 years ago. And the other aspect is that the downside of the drugs, the side effects, are actually worse than we thought they were going to be. So there may be some well-known ones. You may be familiar with these things if you've been on any of the morphine group of drugs, constipation being the most common one. The other one, perhaps the next commonest, being a bit clouded or drowsy in thinking. And often, in my experience, people don't actually notice that until they've come off the medication, when they say, oh, things are connecting much more clearly now. They were pretty foggy before. So we've known about that for a while. The tolerance I've mentioned we've known about for a while. Risk of addiction we've known about for a while. But there are some new things. I've mentioned before the fact that morphine surprisingly can make pain worse, opioid-induced hyperalgesia. A range of other problems that include sexual dysfunction. That's because the opioids can interfere with the pituitary gland, that's the controller of our hormonal systems in the brain. Risk of driving interference, driving impairment, particularly if the OxyContin or cousin is combined with other medications. So the sleeping tablet group, other groups of medications, if they're combined, it's quite likely that you're not driving in a safe way. I suppose that the summary bottom line, the harm is a lot more than what we thought. The benefits are a lot less than what we thought.
You know, you put on weight, you get lethargic, they make you nauseous. You feel like you go to sleep and you wake up not so refreshed. So there's a lot of adverse effects. And I guess ultimately the pain was still there. So I just decided that some of the medication I need to get off and hopefully still manage well.
Another problem with the opioid-based medications is that they can actually wind up the whole nervous system, what we call opioid-induced hyperalgesia, and make pain worse rather than better. And this includes the whole group, so from the simple end of over-the-counter codeine through to the stronger agents, the patches, OxyContin, etc. This can happen with any of these medications. And if you have been on these medications for a time, you may be in a situation where just a very simple thing, a touch, a bump in the supermarket, can trigger severe pain. And then in that situation, perhaps the thought might cross your mind that you need to increase the dose. You don't. In fact, the treatment of this opioid-induced hyperalgesia is to wind the dose down. And as the dose comes down, the pain gets less. And this may in fact happen fairly quickly. It may happen over even days or a week or so, that as the dose comes down, your nervous system settles and pain intensity is less.